Hi everyone, this is an addendum to the first Ronald video, just to look at the case from a different perspective. The first lateral radiograph is taken before the surgery and it shows a negative overjet. The second one was taken after the surgical expansion, but before the second surgery. Of course, there is no sign of the transversal changes, but you can see the decompensation of the overjet as we worsened the malocclusion to prepare him for the bimaxillary surgery. The last one is taken after the bimaxillary surgery, and it shows a correct overjet as the surgeon fixed the sagittal discrepancies, bringing the maxilla forward and the mandible backward. Same here. You can now see in the second radiograph the changes in the transversal diameters of the maxilla after the surgical expansion, but there is no difference between the second and the third radiograph, as sagittal changes are not highlighted with this radiograph. And here we have the pre-treatment panoramic with 3 wisdom teeth. They have been removed in order to get the right fracture line during the second surgery. The lower arch has not been deeply impacted by this treatment. After the alignment, everything has stayed pretty much the same, as the first surgery was performed on the maxilla and the second surgery moved the mandible as a unit backward. These are the initial lateral views. Take a look at the crossbite and the third-class occlusion. The photographs in the second row are taken after the surgical expansion, and as we expected, the crossbite has been partially solved, with the sagittal occlusion being the same as before. It is important to note that if we had completely corrected the lateral crossbite at this stage, we would have had a hypercorrection or even a scissor bite after the second surgery, as moving the jaws back and forth also changes their transverse relations. The third row of photographs shows the situation after the orthodontic surgery, and you can see the first-class sagittal correction as well as the correction of the remaining crossbite, which is more or less what you also see in the last pictures. The initial occlusal photograph shows the upper crowding, and right after the surgical expansion, you can see the dramatic improvement in the transverse diameters. After a few months, the expander is taken off and the alignment sequence is initiated. As we align, we increase the torque of 22, which will be corrected on rectangular wires. Note the amount of relapse of the transverse diameters, as skeletal structures tend to close up again. After a while, it seems even difficult to close the upper diastema. At this point, bimaxillary surgery takes place on a 19 by 25 SS to keep the teeth still while the surgeon looks for the best possible position for the 2 jaws. After the surgery, the only thing left to do is to close the diastemas as much as we can and debond the patient. The front view helps in showing the transversal changes before and after the surgical expansion. And just like in kids, the diastema tends to close spontaneously after the expansion. But in this situation, the transeptal fibers have been cut. This diastema closure is due to the skeletal relapse. Take a look at the sequential position of the canines. Even though the palate has been sectioned, they get additional torque from the pressure of the expander. That torque returns to normal when we remove the expander and settle after a few months. The real bone expansion we got here was no more than half the initial expansion. After the surgery, the negative overjet fades away and the new occlusion is settled in first class, which is pretty much it.